Hello and welcome back from lunch. I hope everybody has full tummies and is ready to be grounded in our afternoon. I'm going to be redundant and give all my reminders about Zoom for those of you who are just joining us. So, our summit today is being recorded. So, we ask that you please keep your microphones off while the speaker's speaking, but you're welcome to have your cameras on or off throughout the day. We encourage you to have them on if you are asking questions. We are going to have a Q&A portion at the end of the session. And so for those times and sessions that are more interactive, please use the hand raise emoji to request to speak. If you need help, the name of the tech support person is at the top of the chat box in the session. You can just direct message them with any questions. And please use the chat to interact with other attendees in our sessions. Our legal disclaimer is also found on your screen. And here are financial disclosures for this talk. As we move into our next session, we're going to be joined by Dr. Saira Kalia. PAL's director, Dr. Kalia, is a highly accomplished perinatal psychiatrist and educator with a wealth of experience in both clinical care and administrative leadership. She has held various roles at Banner University Medical Center, including serving as medical director for outpatient psychiatry and associate program director for the adult psychiatry residency program. Contributions to the field of perinatal psychiatry include launching the psychiatry department's perinatal psychiatry training track and clinical service, and working to expand the department's service in this area. Additionally, Dr. Kalia provides national training for the Perinatal Psychiatry International organization and has made significant contributions to the national curriculum of reproductive psychiatry and the American Psychiatric Association's first textbook of women's reproductive mental health. She is a well-regarded educator, having won multiple teaching awards, including the Arizona Psychiatric Society's Howard E. Wesleyan Excellence in Education Award in 2020. Known for her patient-centered care and dedication to education, Dr. Kalia is well regarded in the Tucson community and has received numerous accolades for her clinical and administrative work. Thank you so much for being here today. I'm going to turn the time over to you, Dr. Kalia.
Thank you so much. I'm super excited to be here, and I'll be honest and admit a little nervous because your speakers so far have been so impressive, inspiring. So I'm going to try to live up to that. Everybody's been so truly amazing. Like I just want to sit down for coffee for most of the speakers, actually. Not the rest, because they're intimidating and how awesome they are. So that's the differentiation so far. As Kendra mentioned, my name is Saira Kalia. I'm an associate professor of psychiatry, and I run the Arizona Perinatal Psychiatry Access Line. We're a very new program, and I'll be telling you about that in a little bit. But more today, I kind of want to talk about approaches to maternal mental health treatment, which could be a bit new because we've heard a little bit about how difficult that landscape is. I have no financial disclosures. I will say that as part of the talk, I'll be using the words heteronormative terms. And part of the reason I'm using heteronormative terms is because that's the data I'm quoting. And of course, the data hasn't caught up to the more inclusive definitions of things like the word woman. So as we talk about maternal mental health, let's start with maternal mortality in general. And I'm sure that this is something that everybody is familiar with, but I really do want to make sure that we're thinking about how far maternal mortality in the US outstrips that of other industrialized nations. I am an immigrant. I was not born in this country. I've been in this country a total of 14 years. And so it's quite horrifying to me, coming from a third world nation, how difficult maternal health is and how bad the outcomes are, given that I have practiced medicine outside of the US and inside the US. And it's kind of jarring at times when you look at the numbers. And it's kind of embarrassing also in that sense. This is just maternal mortality in the US. So that includes both issues of health as well as mental health. For today, I'll be talking a lot more with regards to perinatal mental health. As I go through, perinatal is basically that reproductive time zone. Postpartum is starts, that's very clear and when it starts. So it starts when you give birth, but when it ends, not so clear. So it depends on how you're looking at it. The CDC, WHO, some national organizations kind of used to say it's 6 weeks, that 42 days kind of marker. American College of Obstetrics and Gynecology says it's at least 4 weeks, which is the fourth trimester that the American College of Obstetrics and Gynecology recognizes. And then when you kind of look at the literature, it varies from a mental health perspective. So there's been considerations of considering how far from a milestone perspective that you cross, that helps you get out of the postpartum period. And depending on the milestone, you might not cross because of the child or what your household situation is. So I want you guys to have a bit more of an opener perspective what postpartum can look like, because there is some data that says you're done with the postpartum period when you're crossing into like the child becomes a bit more independent. So potty training has happened or has started school or something like that. And so that dependence on the mother or the birthing person or the primary caregiver has reduced. For some families, that never happens. And so keeping in mind when you're thinking about mental health perspectives, that postpartum period can be a while. In terms of perinatal mental health, it is recognized as a major public health platform, a public health problem by the American Academy of Pediatrics, by the CMS, the American Psychiatric Association. Pretty much all the major health associations will recognize it as a major public health problem. And part of the reason that it is considered a public health problem is it is one of the most common complications of pregnancy. So 1 in 7 people will struggle with perinatal depression or anxiety. When you take that to say perinatal mental health problems, that number becomes 1 in 5. That is a very, very highly prevalent disease issue, which is something to keep in mind in terms of the fact, as you think about like how difficult it is to access care that we've heard about, or how difficult it is to continue to access care. So you might get identified at some point, but to continue to get treatment is a challenge. For comparison, you get screened for preeclampsia during pregnancy, pretty much every single appointment. And it's about 1 in 25 women or birthing persons that will struggle with preeclampsia. The other thing that's really, really crucial to keep in mind, which I really want to highlight, is that perinatal mental illness is treatable and preventable. So you're not doomed to have perinatal mental illness just because you had it before or in a previous pregnancy or you have a psychiatric history. There are ways to prevent it. And if you have it, there are very, very good ways to treat it. People tend to kind of look at psychiatric illness with the sense of like, oh, well, what can you do? That's what's happening. That's really not the case. These are preventable, treatable causes of maternal morbidity and mortality. I want to talk a little bit about the burden of substance use as well, nationally, and then I'll talk about Arizona data for a bit as well. Pregnancy-associated deaths due to overdose in the US have doubled more in between 2007 to 2016. And there has been a significant increase in opioid use disorder. So maternal opioid use disorder at delivery has increased over 4 times in the last 2 decades. This is huge when you think about consequences for both the moms, the babies, and honestly, the families as well. Inpatient treatment for pregnant women with methamphetamine abuse has increased 3 times between 1996 and 2006, and marijuana use has doubled as well. These are pretty high numbers when you keep in mind that this is a huge epidemic in our society. In Arizona, actually, I'm going to pause back before I jump into sort of pregnancy-associated deaths in Arizona. I want to make sure that we're aware of sort of the consideration in terms of nationally. Suicide, excuse me, and overdose combined are the leading cause of death for women in that first year following pregnancy. So once you get given birth, that whole first year following pregnancy, we're going to say, what are you most likely to die from? And I'm sorry to put it that directly. It's either suicide or overdose. And that's something to keep in mind in terms of how common and prevalent these diseases can be and how severely dangerous they can be as well. About 1/5 of women will die during pregnant, and the rest and then 15% will die within that first 42 days of death, and then the rest will be kind of after that. The peak incidence of suicide is 6 to 9 months postpartum, which is also something to keep in mind as you think about policies that we've seen in Arizona. So Access has taken their postpartum coverage from that initial 6 to 8 weeks period and kind of covered the entire first year. That is huge for us because that will capture women who are struggling at that continued later peak in time as well. When you look at deaths in Arizona, Almost half of pregnancy-associated deaths in Arizona were related to mental health conditions or substance use disorders. The more sobering statistic at that point is this one: 98% of pregnancy-associated deaths due to mental health conditions or substance use disorders were considered preventable. So this is data from 2016 to 2018. And this is 203 deaths that we're talking about that were due to mental health or substance use disorders. And 98% of those were considered preventable based on the review conducted by the Arizona Maternal Morbidity Review Committee, which is horrifying when you think about the impact to those families, those children, those communities in terms of those losses. Because suicide is a very, very horrific way to lose somebody, and it has its own ripple effect to the people that are left behind. Not only, of course, not to mention, of course, the person who was struggling with mental illness and chose to continue in that way. Sorry, those were probably not the most appropriate terms. With regards to substance use disorders, this chart is looking at substance use disorders that were the substances associated with with death. So in no way am I saying that marijuana use in Arizona in pregnancy is 27.4%. It's much higher than that. But in terms of substances involved in overdose or mental health related death, opiates were number one, followed by sympathomimetics and GABA agonists. The reason this is important to keep in mind is because when it comes to access to care and treatment, this continues to be an issue. People willing to, or interested in, or feeling comfortable with, or with prescribing medication-assisted treatment or engaging with patients with substance use disorders so they can have a safe, healthy pregnancy. This process gets worse when you think about the racial and ethnic considerations. For example, as we know from a national perspective, that 33% of Black and Latina women are 33 times more likely to experience perinatal mental illness compared to white women. And that's a general statistic that you'll hear quoted all the time. However, when you look at that a little bit more deeply, so African-American pregnant women are more likely to experience more severe illness as well and struggle with delays in getting referred to care or getting appropriate level of care. So they've actually done these studies in various settings, including the VA settings, in terms of maternal health, not maternal mental health, but the degree of the provider that African American women were referred to was probably 1 or 2 degrees less than what other races were referred to. So it kind of permeates our entire system in healthcare, and this becomes a huge challenge. Of course, when it comes to general women of color, which is a bigger category, there is increased risk factors associated with maternal mental illness as well. So the prevalence is higher, and in certain subcommunities, the severity of the disease is much higher as well. For Arizona, we have, this is kind of our racial breakdown in Arizona. So number of live births versus number of pregnancy-associated deaths. So for example, the white population is associated with 43.5% of live births, whereas they have 61.6% of pregnancy-associated death due to mental health conditions. I want to draw your attention also to American Indian and Alaskan Native population. They have about 5.9% of live births in Arizona, whereas 11.1% of pregnancy-associated deaths, which is a pretty high number in terms of considerations as well. So it's a very sobering statistics that I've been giving to you. And most of the time, we don't talk about sort of the dads and the significant others. And I do want to bring it up because it is a pretty high cause of morbidity as well. So 1 in 10 fathers are affected by postnatal depression. With this in particular, I want to make sure that people understand that maternal depression is one of the biggest predictors of paternal depression. Unfortunately, that's the data I have. We could kind of extrapolate that data to like spousal or significant other or partner, but the data says dads. So that's why I'm saying dads. Maternal depression is one of the biggest predictors of paternal depressions, to the degree that if the mom is depressed, it's up to 50% increased risk for the father or the significant other to be depressed as well. So it'll kind of help in terms of making sure that people get care and are thinking about the whole family unit as well. 50% of women with a diagnosis of depression do not receive treatment. And I'll talk about the lack of identification and treatment in a bit as well, and one of the ways that we've come up to treat this. Postpartum depression, and this is untreated postpartum perinatal mood and anxiety disorders are costly. So this is $14.2 billion for all births in 2017. This is specifically looking at depression data and the associated increased cost of medical care, inappropriate medical care, child abuse, and neglect. There's other data sets that kind of expand the cost, right? In terms of discontinuation of breastfeeding, family dysfunction, government sort of social services involvements, lack of productivity, and those data sets come up with bigger numbers. So when you look at those data sets and kind of look at the bigger number in terms of the cost of untreated depression per mother baby dyad is 32,000 per year, because that takes into account cost of child appointments, etc. Moms with, for example, anxiety disorders are more likely to have multiple visits to the pediatrician. If you take that number to be the right number in terms of $32,000 a year, that would apply to 20% of births in Arizona. Again, I'm being a little limited in that. It's probably a higher number than 20% of births in Arizona, and that would average to about $375 million in cost per year just of untreated depression. And that's also assuming that 20% of women got treated. If nobody got treated, that cost is closer to 477. Arizona has about 75 to 78,000 births a year. That number is slowing down a bit. And so that's number for, for those of us that are in situations where numbers matter, or we're having conversations or with advocates or with people who need to know about the numbers. The cost is bigger than that. The cost is increased risk of miscarriage, antepartum, postpartum hemorrhage, gestational hypertension, preeclampsia, issues with attachment, placental abnormalities. So the cost kind of is in the health risks to mom, in the health risks to babies. Babies are more likely to have NICU admissions, preterm birth, low birth weights, neonatal hypoglycemia, increased risk of psychiatric illness in the children, in childhood and in adolescent, poor attachment for the children, and emotional and behavioral issues in the child as well. And then, of course, to the community, as we talked about, in terms of loss of productivity, but also cost of preterm birth. It's pretty expensive, and cost of other mental health expenditures, depending on what could be happening. So the cost is multi-layered in the direct cost to the family unit, in the cost to the community, and then the cost to the healthcare system as well. And I'm not talking about the emotional cost here at all, but I think we can all imagine how challenging it is in that space. And that, I think, becomes one of the biggest challenges with being in mental health care, is that stigma and that lack of understanding at times. It's easier when I have a cast on my arm and people can say, oh, look, that hurts. And that is so much easier. Depression and anxiety is one of their first things that it does to you is makes you isolate. And a lot of the times, a lot of the testimonials you read, articles you'll read, it'll be like, no one could tell I was depressed. And like it was a badge of honor that we can say that, nobody could tell. Look, I appear functional. And I wish we could move that away, that it's not a badge of honor. It's okay if people can tell, so that people can help you in getting access to care. Because the other piece is it's really hard to access care. A lot of women are underdiagnosed or untreated. So 60% of women nationally are never diagnosed, and 50% never receive treatment after they get diagnosis. And overall, 80% of people with perinatal mood anxiety disorders do not receive treatment. So this is an issue. So you might not even get diagnosed, which might be due to the various factors, including just the systems of care we're in. Even if you do get diagnosed, getting care is hard. If you've struggled with a mood or anxiety disorder or any mental health issue, you know how hard it is to ask for help, to step out of the cocoon of fear that it envelops you in, and to say, I need something. And this is harder if you don't engage with other people. And this is a big deal if the systems really help you say it and make it easy for you to express it. Because I feel like once that little initial barrier is broken, people come forth and tell you what's going on. But if they feel like that's going to be a welcome conversation, and that all the conversations I've heard today in terms of systems, in terms of screening, or things in your office that are based on different languages, all of those things are so crucial. They feel like small things, but they're so big in terms of letting people feel like, I can have this conversation with the scenario. It's okay to be open here. And that trust is a huge deal when it comes to mental health care. And this is important because healthy families lay the foundation for a productive society, for a healthy society in general. Part of the reason that people don't get care or are underdiagnosed or undertreated is because we just don't have providers. This is the healthcare shortage professional shortage map. The health professional shortage areas are designations that are used to identify areas and populations within the US that are experiencing a shortage. So there's three categories in general. The first one is primary medical, the second is dental, and then the third is mental health. This is Arizona. As you can see, we're the lightest color, which is the highest shortage in the country. And this is I believe this is their 2021 map. So we're pretty low when it comes to ratio of providers. That's not our only issue, though. We are also we have pretty disparate spread of our behavioral health workforce. So this is Arizona's behavioral health workforce report for 2020. This shows you where the people are. And just for reference, this is pulled from databases of like licensed professionals. This did not include nurse practitioners, and we're working to see if we can get get nurse practitioners in that data set as well. We just don't have that information right now. So this is behavioral analysts, counselors, marriage and family counselors, psychiatrists, psychologists, pretty much everybody in the state. And they are all in Maricopa County, with a few more in Pima County. And then I think this is La Paz over here with 9 people. So we have a very, very urban spread when it comes to Arizona's behavioral health workforce. Again, that blue line is our urban focused care. So this is a huge issue when it comes to access to care. Not everybody's going to travel everywhere. But as you think about the changes that COVID brought in terms of telehealth, those will be making things a lot easier. The other piece is psychiatric care. The total number of psychiatrists in Arizona is 918, which is a very low number when you think about the entire state of Arizona. And the fact that psychiatry is, from a national perspective, the 6th largest medical specialty in the US. So it's internal medicine, family medicine, pediatrics, OB, emergency medicine, then psychiatry. Even in that perspective, Arizona has a lower number of psychiatrists than what we need. Then to add to that problem, there's a lot of cash pay providers for various reasons, again, but that 918 number does not discriminate in terms of like, these are the providers that take access or take insurance. So that's not an accurate number in terms of people who are willing to provide. And then within that, there's very few who are trained in reproductive psychiatry and can kind of provide that specific care. So I'm not trying to depress you. I will get to something positive soon, but it is really hard. So if you're thinking about somebody who's in, for example, La Paz County or Greenlee County, who's struggling, doesn't have access to the providers, if they wanted to, it would be harder. And then kind of figuring out where to get those specific get that access as well. So again, this is just psychiatrists. We're all in Maricopa County. I don't know what's so amazing, but we're all there. And as I said, primarily urban focused. And if you're taking at who's within that urban focused psychiatry population, even smaller, 127 that are providing opiate medication assisted treatment for opiate use disorder. So that's an even smaller number. So if you were trying to find somebody that does reproductive psychiatry plus opiate treatment for opiate use disorder, good luck. This map, bigger number and a bigger variation, is the map for certified nurse midwives in Arizona and OBGYN. So much higher numbers in that, but again, huge disparity in terms of access in terms of, say, La Paz County or Greenlee County. So we're, again, continue to be more urban focused. So the reason I'm bringing this home is because that time period where you're about to have a baby or you are pregnant, that time period is very crucial, because a woman will see a healthcare provider an average of 25 times during that 2-year time frame from conception to baby's first birthday. You have a lot of contact with healthcare at that point. So there's regular opportunities to screen and treat, as we heard, from like pediatric practices, et cetera, today. And also because that psychiatry workforce is so small, most mental health conditions are treated by primary care or OBGYNs. So this is your frontline healthcare providers. The problem becomes frontline healthcare providers don't always have the training, knowledge, or resources, or time, or reimbursement to address maternal mental health conditions. So that is becoming a challenge in terms of making sure that these providers are not unduly burdened or feel like they have the capacity to provide the care that they want to. So we need some form of solution to be able to support this frontline provider. And so what we were thinking about that, as we talked about, part of my first job, one of my first few jobs out of residency and out of training was becoming a training director. So I was the associate training director for 6 years. I did that because I could create the perinatal psychiatry track. I could start educating people into this field. And I was like, I will train enough people. You cannot train enough people. And that was a pretty devastating reality that hit me 2 years ago. And I was like, oh, there's never enough people. And I would train people and they would go into private practices or cash pay only practices. And it made sense. They were graduating with $400,000 in debt. And sometimes when you're working for FQHCs, et cetera, you're not going to make money to pull that back and kind of give and kind of meet your own life goals. So I got that. And so it became really frustrating. I was like, we have to do something else because we are not making a dent in the problem. And so we started looking around to see if somebody else has to have solved this problem. I really do believe you don't have to reinvent the wheel. You just have to find teammates that'll help you push the wheel or whittle your own new wheel, if you will. And so one of the ways that I saw that it was taken care of across the country was perinatal psychiatry access programs. And so they exist for reproductive psychiatry and for child psychiatry. They're designed to address gaps in perinatal population because their goal is to increase the capacity of that frontline worker. So the frontline providers to help them screen, to treat, and to provide resources. The first program was launched in 2014 with a child psychiatry program. And then since then, there have been multiple more that have happened in the US. And they all have one of these three components. The first one, of course, is education. So they'll do free education and training for anybody in their own states. The second is consultation, so real-time psychiatric consultation. You pick up the phone, you get connected to me, and we talk through your case, and I send you references of reproductive safety of those medications, other things to consider about that case, etc. And the last piece is resource and referrals. This is the piece that varies significantly across states. So Massachusetts, for example, has a ton of mental health funding, so they do resource and referral calls. Washington, which is very much similarly laid out to Arizona, they do not do resource and referral. Wisconsin's Periscope project does not do resource and referral. So it kind of varies in terms of what states do what. But most of them will have an education and consultation arm. In terms of whether they work, since, as I said, they've been around since 2014, so 9 years now, and they have been shown to have to work and to be very low cost because mental health care can be expensive, especially if you're going to seek it privately. So in terms of cost, the Massachusetts program costs about 70 cents per month per reproductive age woman for the state of Massachusetts. So, and that's a pretty low cost in terms of the cost to the state. In terms of whether they work, right? They can be cheap, but they should still work. If they didn't work, then and they're cheap, it's still expensive to pay for something that doesn't work. So what they looked at was assessing focus group data and interviewing to see for people who have been engaging and utilizing their content, how much more confident they feel. And they found that clinicians with high utilization rates of psychiatric consultations longitudinally had a very strong association with providing direct mental health care to patients with severe mental illness, such as bipolar disorder. So really building that frontline capacity was something that they were able to prove that they were doing. Additionally, they were also continuing to provide a lot more direct trainings. So for example, the Massachusetts line completes about 0.8 trainings a week, about a training a week. And the Arizona line that we've been around for 14 weeks. And so we've got about 30 trainings under our belt already. So we're training at a much higher rate initially. These are the lines that exist across the state and now across the country. And now Arizona is on the map. The one thing I will say, it's free. It's equitable service. We don't care what race your patient is. We don't care what insurance they have. In that sense, if you as a frontline provider will call us, we will support you. It doesn't really matter. We do collect that information in terms of the insurance information for your patient or the information with regards to your patient's race and ethnicity, because we'll take that back to the States. And we have we have been trying to set up meetings. We've been successful with meeting with, say, Access and Blue Cross Blue Shield, but we're trying to get in to meet with Aetna, et cetera, and other insurance providers, so we can say, this is what we're finding with your clients or your patients that are under your care, and to see if we can advocate in some way for more services for these patients. So what you do, if you're interested in talking to us, just call us. Our phone number is on the page. We're currently half-time, and starting November 1st, we'll be full-time. And part of the reason we're half-time is my lovely, fantastic co-director is coming back from maternity leave in a week and a half. And so I just needed a second person in terms of running it. And from a idea of like being able to provide frontline care, it's been really helpful and kind of impressive, because we've gotten quite a few calls in our first 3 months already. And it's a range of providers. 60% of them have been OB providers. 20% have been psychiatric providers, actually, consulting and saying, how do I take care of this patient? And then calling back and saying, this patient is actually doing better, which is really lovely to hear. And it'll be things like, I think this person has a bipolar disorder, this 26-year-old mom. How do I figure that out? Because I don't have a psychiatrist that I can refer them to. So then being able to say, these are the questions I would ask. These are the screeners you could use. I'll send you the assessment tools. This would be something to think about, because again, maybe that's not part of your training. It is part of mine. And for a service that kind of covers the state of Arizona, we're a very lean setup, because we've got about 1.2 psychiatric FTE to kind of cover it. And so it is a very lean setup in terms of providing the care that we do. And as I mentioned, you can ask us to do trainings. Right now, we don't have CME provision, but in a month or two, I think we'll be able to provide CME for those trainings. As I said, free again. If there is anything that you do want that is not on our list, let us know, and we'll see if we can create that training for you. Because really the goal is improve the frontline capacity for Arizona and kind of take care of our moms and our babies. Additionally, even though we don't do resource and referral, because we just don't have the setup for it, and in Arizona, things change so fast. A lovely program will come up, and then in a year, they won't have funding again. And so they'll go away. So kind of keeping track of that becomes challenging. What we do have is a Arizona-based map on our website, and you can kind of go county by county, and it'll give you resources for the county. I'd hope to do a little bit of like basic general principles, but I know that I'm coming up to time. So what I will do is just a little sneak peek of general principles, and then we might have to, I know that I'm going to have to give you guys time for questions, but I'll say that by age 44, 85% of US women will be mothers. And you've heard the statistics in terms of unexpected pregnancies are about 50% of all pregnancies. What I want to make sure that you understand about that statistic is that's for all pregnancies. When you talk about patients with psychiatric illness or mental health conditions, that number of unexpected pregnancy goes from 50 to 75 up to 80, depending on the number you're looking at. So when you're looking at that subpopulation, it is you have to expect pregnancy. It's going to happen. And so if you're prescribing for that population, talk about contraception. If you're prescribing for that population, talk about the reproductive safety of those medications. So it's essential to discuss pregnancy safety when you're prescribing the medication. They don't have to be pregnant. They can tell you they never want to be pregnant. I don't care. Tell them what the safety profile is of that med. And if you don't know the safety profile, call us. We'll tell you the safety profile of the psychiatric meds. In this scenario, and the other thing, and I'm not going to go through all of this because I know that I have, 3 minutes left, I think. I have to get 10 minutes for questions. Okay, thanks, Kendra. The one thing I will say is this one: minimize the number of adverse exposures. We've talked about the risk of disease. It's a risk-risk conversation. There's a risk of disease, there's a risk of medications. Yes, we know certain medications have lower risk, but it's not fair to that mom to expose them to the disease and their medication. So if you're treating them, treat them, get them to remission, get them to outside of disease state. That is the goal, so that they're not taking on the risk of preterm birth as conferred by the perinatal depression, and then also the risk of preterm birth as conferred by the medication. That is not okay. If you're treating them, treat them to remission. And that means assessing them again and again, because a lot of the times it'll be, let me give you some medications and you're starting to feel better. Great, we're going to stop there. Better is not the goal. Good is the goal. remission is the goal. So make sure that you're keeping that in mind. And if you are not the prescriber and you're hearing this, please help your patients advocate for that as well, because that's kind of the consideration. Talk about marijuana use because it's very common in our state and it's not helpful in terms of pregnancy, but I will not go on that rant today. But as I said, risk discussion. The last educational piece I want to make sure that I leave you guys with is this one. Perspective on risk, right? The rate of major malformations is 3 to 4%. Everybody is at risk. Anybody who gets pregnant, that is the rate of congenital malformations in the general public. A medication has to beat that risk to say it is causing congenital malformations. So if it says SSRIs, I found that Prozac has a 2.9% risk of congenital malformations. That is at baseline. So that is not an increased risk. That is your baseline risk. Pretty much every medicine that you'll study would kind of hit that baseline risk, because that's just a normal baseline. So when you're talking about risk, keep that in mind with the patient so that they understand, which is a very hard thing to accept, that risk in pregnancy. But if you're never aware of that, that's even harder later on. And so with that, I'm going to pause here. I'm going to say, if you haven't heard about us, I'm glad you're here, and I really appreciate the opportunity to talk to you. I really want to make sure that you guys are helping us get the word out. I do not get paid more if I get 6 calls or I get 1 call. I just want more calls so we can do what the mission was. So we would love to make sure that we're coming to your practices, helping you with the education piece, or if you want to call us, please do. For that, I'm going to stop, check in, see if I've gone over time.
No, that was perfect. Thank you so much. We have some time for questions. Raquel, I thought I saw a couple coming in.
There were a couple have been answered just as like resource links and things, but we have any evidence-based studies around folate deficiency and depression?
Actually, yeah. And that's the other thing that's coming up in terms of cool research. So folate deficiency in moms is actually pretty common. And part of the other issue that becomes is there is a genetic mutation called MTHFR mutation, which if you write that down, it comes up with a very bad word, which is how we learned it in med school. But it's a pretty common mutation, and it's about 40% of the population. What that does is it affects your folate being metabolized and sort of creating serotonin. So 40% of mom have that issue in terms of folate metabolism and creation of serotonin. That becomes a huge issue in pregnancy, because in pregnancy, your folate needs are higher, right? So all of that is going to create the neural tubes and the neural mechanisms in the baby. So folate deficiency kind of increases for all of us who have that deficiency. So for example, I have that deficiency, and it's your need for that is much higher. And so if you're giving that to baby, and that's also going to be creating your own serotonin and your own pathways, then you're going to be deficient, and you need to consider supplementation higher or figuring out if you have that mutation. But yeah, there are some increasing studies about that, which is also why there's increasing data sets. So for example, Sage Therapeutics, the company that makes brexanolone and zuranolone, they are doing some studies around their own patented vitamin formula for vitamins for antidepressant effect. So we'll kind of see what that comes out to be, which is an interesting perspective because you can't really patent vitamins in the US, but we'll see where that takes us. Lakisa, thank you so much. I've seen your help in the chat. I appreciate it.
Yeah, she answered most of the resource questions, so thank you for that. That looked like the only question. So again, if I missed anything, please just raise your hand, and we'd love to chat with you.
I have a question. This is Katrina Papalier.
Hi.
Hey. Okay, so first of all, with everything that you just referenced, Dr. Kalia, I'm never going to remember that I was walking around my house and I'm on the phone today. I was curious if I could even just email you, because my daughter does have the gene. And yes, anyway, so but another question is to this effect is, with everything that you're doing, is there any progress being made on like how we can kind of reach out to different providers such as pediatricians, and then different OBGYNs? I mean, are we finding that the like normal platforms, are we able to reach these providers, or are they harder to reach? And just inform them of your work and everything. So sorry.
Yeah, I just sent you my email address directly for the first part of it. And the second part of it is yes and no, right? It's easy. We're doing what we can. Like I even did some cold calling in terms of reaching providers, and it's going to be a slow sort of process in terms of getting people to know who we are. Honestly, though, Arizona is kind of cool. We have, in the sense that there's so many energetic, excited people who really want to work in this area that are really helpful. And for context, we've been speaking with sort of the national network who kind of helps run all of these lines. So there's 20 other lines. And for reference, they were like, what, you've gotten 60 calls in 3 months? People get their first call 2 months later. So that is the frame of reference in terms of how amazing Arizona is and how great, how helpful people have been in helping us get the word out. The other piece is OBGYNs, pediatricians, family medicine docs, they're busy. They're very, very busy docs. So they'll hear about us and they'll be like, you sound great. But it'll be a matter of the day that I need you, right? That's the day they'll think of it. And so making sure that it's we're getting the word out on a repeated way. And we're starting to do that. But if you feel like you meet your pediatrician and you're like, have you known about us? Please do that. That's been actually one of the resources. And a lot of the times patients have been telling their doctors to call us, which is so wonderful also.
That is amazing. And I was just curious, how are you bringing in the nurses in Arizona about this? Sorry, pups.
We have been, actually the nurses are, especially like LND nurses, they're lovely. So we've gone to like hospital systems and just walked in and said, hey, do you know about us and stuff? So we've been going that way. And again, nurses, I think feel like they have a very united network. So they've been like helping me get the word out. But if you know people, send me, I will contact everybody.
And last question, and forgive me, because I know I've shared your information. I'm also with First Things First, and so I've shared your information with our different regional directors in Northern Arizona. But I know that there's a huge interest in the Perinatal Access Hotline, and of course in Postpartum Support International and all of that, with the providers that are not only in the northern communities but also tribally located. Do you find that you are getting reached out to by tribal providers as of yet, or nothing as of yet? Okay.
Nothing from tribal as of yet. And actually, just as a tangent, we are in the process of figuring out if we can get grant funding to start a pediatric line. So both pediatric and perinatal lines to sit together, because again, cross promotion. So we're hoping that we can do that as well. And then we'll know in the next month or two. And that'll help us kind of double down our efforts. Because honestly, moms, there was an article that said moms are like the Reese's peanut butter cup. They're and then you're the wrapper that gets discarded because what we were after was the cup inside. So if we figured we'll go after the internal cup as well, and that'll probably help us get the word out more about moms as well. But if Katrina, you have any connections with tribal, I've sent you my email. Please let me know. I'll follow up.
Yeah, we'll definitely be in touch. Thank you.
Awesome.
And thank you for the pediatric line too. That would be amazing.
It will be. I'm really hoping that it works out. I think there's another hand up, Lakisa.
Greetings, Dr. Syra. How are you?
Good. How are you? It's so good to see you. I haven't seen you since Phoenix.
I know. Wonderful presentation. Thank you so much. You'll have to forgive me because I think I was returning to my computer as you were addressing this. So if you don't mind repeating a little bit, but one of the concerns that I'm hearing from community-based providers is the collection of demographic information and the possible tracking of patients and people and their information. So could you just speak to that just a little bit?
In terms of what information we collect for the line and how that could be.
Right. And I think I heard you saying that you all were using it for advocacy purposes. So we can look at or prioritize certain populations based on the call and the information that you receive.
Yeah. So for a lot of the lines across the country, some are HRSA funded, some are funded like we are in terms of like a state level Medicaid funding. So we're only funded for 2 years. And then others are HRSA funded that are 5 years. All of them have to collect some level of data. So the data we collect is where in the pregnancy is the patient, which I kind of need that for just the reproductive safety piece of it. What insurance they have. I don't want insurance numbers, member numbers, nothing like that. Just like commercial or access. And if you know within commercial which one, that helps. And then if they're and what county they're calling from. And we actually collect more information about the provider. So we can say we're getting more calls from NPs or midwives, and therefore we're going to be able to advocate for getting more training for NPs and midwives that is going to be free and mediated through us if they want that or not. So while we do collect on actually ethnicity and racial data as well. So the goal of that is not to identify the patient. The goal of that is to be able to say, this is the spread and this is the subpopulations that we're getting called on. And I will be honest, even though I don't have a huge number of N right now, it's about 60 calls, 60 to 64 calls that we've had so far. Clearly, we're getting more calls on Hispanic and Latina women and African American women. And I can't draw any conclusions from that, but firstly, we have to take that data back to Access because they're funding us. And part of that is going to be what subgroups have what disease, which counties have the most disease once we start to get more sort of known across, and what can we do across across the state in terms of building more funding and building more state-based programs. And one of the things has been, can we acknowledge PMHC certification? So can we acknowledge providers who are sub-certified in this field? And if that means giving them a little bit more money in terms of their services so that they are honored for the work that they do, because it's not an easy field. It is not an easy field by any means. And it's really hard. Like I've done this work for a while. There's been days where my patient panel is a rape case after rape case after rape case, and their afternoon is depressed mom with so many things on her. It wears you down. And I've been very, very privileged in the way my practice can be built, but it's really, really hard, especially if you imagine you're in a rural community like Greenlee has 9 providers. Like that's a lot of pressure. It's really hard. So I think part of the goal is to be able to advocate for more services and hopefully advocate and support the providers that are doing the work.
Thank you for the work that you do for that
Went on
response.
random. Thank you for the work you do.
Thank you, everybody. Thank you for participating. Thank you, Dr. Kalia. And everybody, we're going to have our short break. We're coming back here at 1 o'clock. So brief break, go get active on Whova, come back and see us again in a couple minutes.